Okay, we will have a case discussion, presentation and discussion with journal appraisal. Okay. Time allotment will be approximately 2.5 hours. Hopefully we don't go beyond it. Okay. And the online platform will be the Zoom. Okay. I'll be your facilitator. My name is Dr. Reynaldo Ong Hoson. Okay. So here listed are the 7 mentees. Okay. Francis Andaya, Wendy Andaya, Shamil Ang, Gabriela Angluben, Patricia Arevalo, Jejomar Arojado, and Abraham Shanoya. Okay. I hope you have gotten hold of the learning objectives. So we start with this one so that we have a common expectations. Okay. So let me read to you the learning objectives. So given the patient, the mentees provide the details and the clinical data clearly and concisely. I like to add the word relevant. So you should do it relevantly, all relevant details and information that are needed. Okay. Then number 2, provide a good history and present complete physical examination as one would proceed in a bedside preceptorial. Again, I like to emphasize the word relevant. Given or give the differential diagnosis and explain how the group arrived at the primary working impression. So I like to add the word, the quality parameter as efficient. Okay. Now, number 4, explain the pathophysiology of the disease at hand and may include the theoretical data or possible existing epidemiology of it. Again, the word relevant as a quality parameter. Then number 5, provide options for additional diagnostic maneuvers or studies. And then number 6 will be provide the surgical plan or medical plan if the patient does not need surgery, and other treatment options. And lastly, present a journal appraisal of the relevant clinical question regarding the management of the patient. So 1, 2, 3, 4, 5, 6, 7 learning objectives. Is everything clear? And do you agree with these learning objectives?
Yes, po, sir.
Okay. Now, in the evaluation of the mentees, okay, I was given this list, okay, history and physical examination. There's some points here, 1, 2, 3, 4, 5, okay. Differential diagnosis, diagnostics, treatment plan, relevant journal, psychosocial concerns, questions and answers, communication skills, presentation. So this is the new form given to me. Okay, it has a total of 45 points. Okay, so I'm going to grade you based on these parameters. Okay, so the grading will be basically, I was told by Patricia, it will be a group grading, but I have started with individual grading before. Okay, to be consistent, I will do the individual grading again this time. Okay, so with the individual grading, we have to put emphasis on the active participation of the students in this group discussion. So you can ask, you can do this by answering questions, if I ask questions, and then asking questions to the facilitator, at least 2 questions per mentee. So I would also consider your contribution to the case report and journal appraisal. So can I ask you, Patricia, to write down your contribution to the report, the contribution of its members to the report, so that I can take this into consideration in the grading? Okay. Is that okay with you, Patricia?
Yes, po. I'll send po to you, sir.
So, but I'll be also using this one. This was the past criteria that I use also given to me by the committee, but I think I don't know whether they have changed it or not. Okay, so there'll be a history and physical examination. Okay, that was mentioned in the one that I previously presented. So you must be able to enumerate and discuss the pertinent negatives and positives. Okay, and then primary working impression on differentials, summarize the salient points of the case, arrives at and justify the primary working impression, and discusses differential diagnosis. Okay, then plan of management, both diagnostics and also preparation for the plan of treatment. So you formulate the plan of diagnostic workups to confirm the 5 primary impression, if there is a need to do that, according to standards of care with consideration of cost efficiency. That's why you notice in my template, I put that one of the factor, the parameter that you have to use is cost. Then availability will be the last one. Okay. The plan of management itself, but therapeutics and including surgery if it's indicated. So decide on the viable plan for therapeutic approach, whether surgical or medical or conservative or both, and explains the rationale behind it. Okay. But if there's a need for surgery, put more focus on the surgical plan. Then lastly, post-op complications, prognosis, and surveillance. So explain concisely what to watch out for in the immediate post-op course within 30 days and considerations regarding prognosis and surveillance. Okay, if cancer, surveillance if it's cancer. Okay, so total of 45 points. So clear? This will just complement the other one that was presented to us. Okay, is this clear?
Yes, sir. Clear po.
Criteria for journal appraisal. So will be the research questions based on the clinical problem related to the management of the case, description of how the article was sought, summary of the journal, and then journal appraisal. You were given the checklist for this, right? Okay. Okay, clear? Okay. So this is how you will evaluate me, because I also look at the criteria that will be used to evaluate the mentee, the mentor. Okay. So in this class, the teacher explains the objective, expectations, and various requirements of the course, encourages the students to think critically or creatively, communicate clearly, answer students' questions clearly and adequately, able to help students understand complex ideas related to the subject matter, uses engaging and helpful learning exercises and activities, relates the subject matter to issues and development in the discipline and or real life concerns, encourages students to participate, make himself or herself available for consultation. Okay, this has been made part of the criteria that you will evaluate me. How I'm going to do this? Okay, I'll make some suggestions for this. Encourages students to express their ideas and viewpoints, communicates and interacts with students in a positive way, shows respect for students' diversity and individual differences, makes full use of the required hours for learning, provides fair and timely feedback on student performance, and then uses clear criteria to evaluate students' performances. Okay. So the other parameter, were you given this list? May I ask Patricia, were you given this list?
Sir, it's part of our set po. So we're asked to fill out naman din po talaga.
Okay, you have a copy of this one. Okay.
Yes po, we have a form po.
Okay. So number 2, in relation to your learning experience in this class, what does your teacher do that you find very helpful, effective? How do you think can teaching in this class be improved to enhance your learning experience? And then how can the teacher utilize technology more efficiently to enhance your learning? We're still using Zoom. Okay. So there might come a time that we have to go back to the face-to-face already. Okay, but at the moment, it's still Zoom. Okay, so there's a item there, make myself available for consultation. Right away, I'm going to tell you, okay, I have a Facebook Messenger. You can contact me through this one, and then the other one is this one. Then my email address, and then my cell phone is also my Viber number. And I would suggest that you request friendship to my Facebook profiles because I post a lot of medical things there. Okay. Okay. So out of the 15 criteria that you're going to evaluate me, I think I have done this one already. I just finished with this one. Explain the objectives, expectations, make himself available, and then use as criteria to evaluate the student's performance. Okay. Now, the last thing that I want to tell you in this orientation is that you have seen this video, okay, on the YouTube now. Then later on, I'm going to give you a so-called online collaborative interactive learning or online learning from evaluation test exercise on this topic on patient management process. I'm going to give you a form which you're going to fill up. It's just like a test, no, but don't be anxious about the test. No, okay. So it's very easy. You just take the test, and then if you don't get the a perfect score, you just repeat it until you get the perfect score. Okay, that's why it's called CUM online learning, CUM evaluation test exercise. The word there is exercise until you get the perfect score. Okay. So any questions? Are we clear now? Okay.
Yes po, sir. Clear
Okay,
po.
so what we're going to do, I have read your report as well as your journal critical appraisal. Okay, so what I would suggest that we do is that we tackle the journal appraisal first so that we can put it aside, then concentrate the rest of the time on the case discussion itself. Is that okay with you?
Okay po, sir.
Okay. Sige. Who will present the journal appraisal?
Sir, I'll share screen po.
Sige. I have to give you permission to share screen?
Sir, may permission naman na po.
Meron na. Okay.
Yes, sir.
Okay.
Okay. Good morning for everyone. So we're block C. We're going to first discuss the journal appraisal for this morning's small group discussion. So for the clinical question, among patients with papillary thyroid cancer, how safe and effective are other surgical approaches compared to conventional thyroidectomy? Now, for this one, upon doing the history for the patient, he was anxious for the surgery. Thus, the mass started to grow on his anterior neck 4 years prior to admission. And for that kaya po siya lumaki ng ganun kasi he was somehow afraid for the surgery and for the outcomes of the surgery. Also, another concern of the patient would be currently before both the surgery, he was experiencing transient. This one our clinical question would be, among patients with papillary thyroid cancer, how safe and effective are other surgical approaches compared to conventional thyroidectomy? Next slide, please. So for the search strategy, so PubMed was used as the search platform for the journal appraisal. Search terms were used to cover for the desired population, exposure, control, outcome, and methodology. Based on the clinical question, we use the mesh terms, title, abstract, or all for all fields, whether applicable, and Boolean operator or to expand and end to narrow them. Now, systematic review and meta-analysis was chosen as article type since it provides the highest level of evidence, particularly on the established surgical procedure, such as the thyroidectomy. Now, articles were also filtered yielding studies that were published in the last 5 years. Next slide, please. So, next slide, please. Okay. So the search strategy resulted in 8 articles, as can be seen on this slide. Next slide, please. So the article was chosen based on whether it can answer our clinical question. So this journal entitled Comparison of Total Endoscopic Thyroidectomy with Conventional Open Thyroidectomy for Treatment of Papillary Thyroid Cancer, a Systematic Review and Meta-Analysis. So we can view a copy of the article using the QR code on this slide. Next slide, please. So for the study design for this journal article, systematic review and meta-analysis. For the method, medical literature databases such as the PubMed, MBase, Cochrane Library, and Web of Science were systematically searched for articles that compared total endoscopic thyroidectomy and conventional open thyroidectomy in papillary thyroid carcinoma treatment from database inception until 2019. The result of this study, total endoscopic thyroidectomy was found to be generally equivalent to conventional open thyroidectomy in terms of surgical completeness and adverse event rate, although total endoscopic thyroidectomy resulted in lower levels of transient hypocalcemia, a smaller number of retrieved lymph nodes, and better cosmetic satisfaction for the patient. Now, conventional open thyroidectomy was associated with shorter operation time and lower rates of transient recurrent laryngeal nerve palsy. So for the conclusion of this study, the results show that in terms of safety and efficacy, total endoscopic thyroidectomy was similar to conventional open thyroidectomy for the treatment of thyroid cancer. Tumor recurrence rate and the level of surgical completeness in total endoscopic thyroidectomy are similar to those obtained for conventional open thyroidectomy. Total endoscopic thyroidectomy was associated with significantly lower levels of transient hypocalcemia and better cosmetic satisfaction, and thus it's the better option for patients with cosmetic concerns. Next slide, please. So for the appraising directness, so for our clinical dilemma, so for the population, patients with papillary thyroid carcinoma, and for the article research question, so same. For the population, patients with papillary thyroid carcinoma. For the exposure, for our clinical dilemma, other surgical approaches of doing thyroidectomy. And for our article research question, this employs total endoscopic thyroidectomy. For the control, both conventional open thyroidectomy. Now, for the clinical dilemma, the main outcome would be the safety and effectiveness of the procedure. Now, for the article research question, the outcomes they measured include surgical completeness. So this includes postoperative thyroid globulin levels, recurrence of the tumor after long-term follow-up, adverse event and complication. For example, transient recurrent laryngeal nerve palsy, permanent laryngeal nerve palsy, transient hypocalcemia, permanent hypocalcemia, operative time, number of removed lymph nodes, length of hospital stay, and patient cosmetic satisfaction. And for the method, both systematic review and meta-analysis. Next slide, please. For the appraising validity, so number 1 question would be, were the criteria for inclusion of the studies appropriate? And the answer is yes. So as stated in page 2, paragraph 4, lines 2 to 4 of the journal article, they included randomized clinical control trials and non-randomized clinical trials as their data set for this study. Next slide, please. So another question would be, was the search for eligible studies thorough? The answer is no. So as stated in page 2, paragraph 3, lines 2 to 3 and line 7-9 of the journal article, The study was conducted during March 2019 and they used four electronic databases: PubMed, Embase, Web of Science, and Cochrane Library. Now, no restrictions was applied to the language or the date of publication. However, no mention was made of manual searches done for unpublished articles, making the publication bias as a possible factor. Next slide, please. So another question would be, was the validity of the included studies assessed? The answer is yes. So as stated in page 4, paragraph 2, line 8 to 10 of the journal article, studies were assessed for measuring quality by Downs and Black scale. So and they found out that the score ranges from 20 to 32 points, with an average of 28.6 points. So just to give an overview po, Downs and Black scale po is a validated tool for assessing randomized and non-randomized studies. So the scale evaluates study reporting, external and internal validity, and the power of the study to determine if the findings are statistically relevant, with maximum assigned score of 32 points. Next slide, please. And lastly po, were the assessments of these studies reproducible? And the answer is yes. So as stated in page 2, paragraph 5, lines 1 to 2 of the journal article, the study employed 2 reviewers that reviews independently for all eligible studies using a standardized format. And any differences in applying the inclusion or exclusion criteria between the 2 reviewers were resolved by thorough discussion and mutual agreement. Next slide, please.
So since we were able to already establish the directness and validity, we now proceed to presenting the results. So with this, we first answer the question, what are the overall results of the review? And so first we check whether the authors presented study characteristics of the included studies, which the authors did as shown in table 1. And however, there was no such summary for excluded ones, although they mentioned that they excluded those which did not compare total endoscopic thyroidectomy to conventional thyroidectomy, or conduct statistical analysis of the clinical data, duplicate publications, narrative reviews, and opinion pieces. So included studies were from China and Korea, composed mostly of case control studies that were published in 2009 to 2018, involving adult age groups, mostly females, with or without reported metastasis, tumor size of at most 2 centimeters, and median follow-up of up to 58.3 months. As Jejo mentioned a while ago, on the Downs and Black scores, which the authors used to assess the validity of the included studies, the last column showed that the Downs and Black scores were relatively high, indicating good quality, validity, and power of the studies included. Next slide, please. So initially, we thought of presenting individually the forest plot since this is a meta-analysis, but in the interest of time, we have summarized the study outcomes, point estimates, confidence interval, interpretation, and heterogeneity. So in summary, total endoscopic thyroidectomy was similar or was found to have no significant difference with conventional thyroidectomy in terms of its incidence of permanent post-operative recurrent laryngeal nerve palsy, permanent post-operative hypocalcemia, post-operative thyroglobulin levels less than 1 nanogram per ml, and recurrence of post-operative tumors. That is indicated by the confidence intervals straddling the odds ratio of 1. So if it straddles 1, that means the confidence interval captured the null hypothesis, which is there's no significant difference. So in terms of heterogeneity naman, it shows there that there's no significant heterogeneity. Next slide, please. And on the paper po, as also mentioned by Jejo a while ago, the authors claimed that compared with conventional thyroidectomy, total endoscopic thyroidectomy has significantly lower incidence of transient hypocalcemia and significantly better patient cosmetic satisfaction. And if you look at the 95% confidence interval, we would agree with the authors, since for cosmetic satisfaction, which is in terms of taking the weighted mean difference between the two, the values do not straddle zero. So meaning there is a positive um, effect or greater effect of a total endoscopic thyroidectomy over conventional thyroidectomy. Same goes for incidence of transient hypocalcemia, which the 95% confidence interval does not straddle 1. However, we would like to present our concern because here we see that in terms of heterogeneity, we see that the studies included sa last column po, both for cosmetic satisfaction and incidence of transient hypocalcemia are actually significant, which means there is significant study-to-study variability, meaning parang the included studies were slightly different in terms of population or exposure or control or methodology, such that we may not be combining all the studies may not be fully justified because nga the included studies are heterogeneous. Next slide, please. So consequently, so what the authors did was to make a subgroup analysis in order to address this initial overall heterogeneity. However, it shows here that even if they did a subgroup analysis for the ones without central lymph node dissection, while it did eliminate the heterogeneity in transient hypocalcemia, it did occur at the expense of significant difference between the two operative methods. So nawala nga yung heterogeneity, pero hindi naman na significantly different between the two. So that's also another concern for their claim on TET having significantly lower incidence of transient hypocalcemia. Next slide, please. In terms of cosmetic outcomes naman, which is their second claim, there was no subgroup analysis to address the initial significant heterogeneity. But all individual studies naman show greater patient satisfaction rates. Lahat naman sila to the right. However, still there is overall significant heterogeneity pa rin. So therefore, next slide please. We believe that the results claimed by the authors are inconclusive at this point due to the significant heterogeneity for the following tests, the ones boxed in red. Next slide, please. And then the two results naman po with significant differences include the number of lymph nodes removed, which is less in total endoscopic thyroidectomy, and longer operative time for total endoscopic thyroidectomy. Next slide, please.
Next, after interpreting our results, we check the applicability of the study to our patients. So there are several factors, biological and socioeconomic. So first we look at the biological, namely sex, comorbidities, race, age, and pathology. So for sex, our patient is a male. However, in the appraised article, majority of the participants were female, with over 80%, 86% of them being female, considering that papillary thyroid cancer has female preponderance with a higher ratio of females to males with 2.5:1, according to a study by Tuttle. And in this study, there was also no mention of whether sex affected the reporting of the cosmetic satisfaction. And there are also no robust studies showing whether males are less critical about their physical appearance. So this is sort of in doubt or uncertain. However, there are a certain number of studies revealing that females are more at risk of transient post-thyroidectomy hypocalcemia, which could suggest a sex hormone factor influencing post-thyroidectomy parathyroid function, while male sex is independently predictive of higher intact parathyroid hormone after total thyroidectomy. So for comorbidities, our patient has no known comorbidities, and in the appraised studies, there's also no mention of comorbidities in the inclusion criteria. The authors also did not present any participant characteristics in terms of comorbidities, which could affect data on hypocalcemia incidence since there may be concomitant metabolic or endocrine conditions po. For race, our patient is a Filipino, so Asian. And in the meta-analysis, which included 20 studies, these were primarily conducted in China and Korea. There's also no mention whether race affected self-reporting of cosmetic satisfaction. And Asian race is not found to be an independent predictor of hypocalcemia after total thyroidectomy. For age, the mean age of participants in the studies ranged from mid-30s to 50s, while our patient is 22 years old. And again, there's no mention of age affecting the risk of hypocalcemia or cosmetic satisfaction. And lastly, for pathology, our patient has papillary thyroid carcinoma, and his greatest tumor size is 5.8 centimeters in diameter. However, all of the studies analyzed patients who had papillary thyroid carcinoma with tumor size at most 2 centimeters. So this would indicate that we should be cautious in interpreting the applicability of the study for this patient, and there may be differences in surgical difficulty and outcomes. Next, we also consider socioeconomic factors. So in the study, no socioeconomic factors were mentioned by the authors that could affect applicability of outcomes. And when we search for availability of the alternative surgery, it's currently available in the Philippines. However, in St. Luke's Medical Center and Medical City, there's also currently no PhilHealth case rate or standard package cost available. However, we also need to take into context the patient situation, such that he is a 22-year-old male, he works as a rice farmer, and he lives in Nueva Ecija, which could impact his access to healthcare since this is in a province and they don't have several public hospitals there. His health-seeking behavior is, as we will find out later, not very good. And his financial status, he is having difficulty with finances, which is why he was referred to PGH.
So for the individualization, we have to determine or calculate first the number needed to treat in order to prevent, let's say, a particular harmful effect or safety issue. Let's say incidence of transient hypocalcemia. We are able to calculate this since the only significant difference in odds ratios have inconclusive results, which I presented a while ago, due to significant between study variability. However, the other outcomes with significant difference include weighted mean difference for the number of lymph nodes removed and operative time, which are lower and longer respectively for total endoscopic thyroidectomy. For the number needed to treat cannot be computed as well for these outcomes expressed as weighted mean difference, and the authors did not provide the raw data, so we were unable to calculate as well. Since there are significantly more lymph nodes removed and shorter operative time for conventional approach, total endoscopic thyroidectomy is still a viable option, considering that the patient has supraclavicular lymph node extension, and we can advise the patient to decide based on the results presented.
So for our conclusion, given the results, we were able to decide that the study is direct enough and that the study is valid enough to address our clinical dilemma. Based on the results, total endoscopic thyroidectomy appears to be safe and effective with significantly lower incidence of side effects and improved cosmetic outcome compared to conventional open thyroidectomy. However, this was just a claim made by the authors, and we were able to see that there is significant heterogeneity, making them less reliable or established. And as discussed, applicability is also a concern for this patient since there are differences in the tumor size and pathology. The patient's age group and sex are not aligned with majority of the participants, and the availability of the alternative surgical approach may not be accessible for our patient in his context. Thus, for our conclusion, we decided that recommending the total endoscopic thyroidectomy to improve cosmetic outcome and lessen risk of side effects is not productive, and conventional open thyroidectomy is still superior in consideration of the patient's context po. So this was the end of our journal appraisal po.
Okay. Okay, would you like to stop sharing? Okay, so any questions from the other participants? Francis, any questions, any comments?
Sir, I was just thinking po, yung applicability of this study, since the procedure is not available po in PGH and yung alternative procedure is only available in the private hospitals, would it still be a viable option for the patient considering his financial difficulties po?
Okay, so that's a nice question, but if you had read my patient management process, that will answer your question, right? So we're talking about selection of treatment. Okay, so in the selection of treatment, you use the BRCA process, right? So benefit, risk, cost, availability. You put the heaviest weight on the B. It's arranged in that way, BRCA. Okay, so first priority is the B. Okay, benefit, then the risk. Then usually when talk about the risk, we don't usually recommend a treatment that will have an acceptable risk, diba? Okay, so usually there are risks, but lower, acceptable, and then you just compare the various risks of the different viable options, no? And then the cost, availability. Okay, so if you talk about that's the reason why I put A as the last. Okay, so we know that endoscopic thyroidectomy or endoscopic procedure is available in the Philippines. We know that, no? Okay, it doesn't have to be in PGH, no? Okay, so if a patient wants to have it, no, okay, then you can refer that patient to that particular center that would do the endoscopic procedure. Okay, I won't talk about the I'm not using the word endoscopic thyroidectomy because my feeling is that it's not applicable here. Okay, because you have modified radical neck dissection to contend with. Now, your study is mainly on the thyroidectomy with probably a few lymph nodes along the central neck, diba? Okay, but you have big nodes on the side, no? Right? So that's one of my comment here right away. No, so it may not be applicable right away if we want to use that. No, okay. Now the cost again, if the patient can afford it, no, then you do it. No, you can ask the patient to go to a center that do it. No, okay. Now let's go back to the benefit and the risk. No, okay. So yung benefit, as I said, you have to know the indications first. No, okay. Know the indications first before you try to compare the various options. Okay. So here, indications will be to remove the thyroid carcinoma, okay, in the thyroid itself, and also the lymph nodes on the neck. Diba? Okay.
Yes, sir.
So then you think of the various options. You can say, okay, endoscopic thyroidectomy plus neck dissection, endoscope conventional or open thyroidectomy, and modified radical neck dissection. Okay. Okay. So you compare the two. Is it can you do it adequately with endoscopic thyroidectomy and neck dissection? Okay. So you ask that question, or can you do it better with open procedure? No. So if from the very start, endoscopic thyroidectomy and neck dissection is not indicated, then you don't consider that anymore. Okay. So you go for the open right away. No. Okay. So you tell the patient, okay, here are the options. You present to the patients. These are the options, but this is not applicable to your case. No? Okay. So you just have to inform the patient nowadays because they're aware of so many procedures being done. No? Marami yan, di ba? So paminsan they fault you if you don't explain everything to them. No? Sabihin nila, biased ka. No? You're biased on your procedure. You're not thinking of on the other innovative procedures. No? Okay. So you have to explain these are available, but this is a better option for you because it's you cannot probably there are no reports of are there reports on modified radical neck dissection? Are you aware of that? Wala na? Wala pa? Did you come across that? Wala. Let's assume wala. Okay. Okay. So I'm asking you because probably because you're looking if you're when you search the journals, you might come across it, di ba? Okay. So mukhang wala pa, no? Saka yung na-present ninyo, okay, I noticed the tumor size is only 2 centimeters, di ba? Okay. Yung sa pasyente ninyo, more than 5 centimeters, laki, di ba? So it might not be applicable, no? So you tell the patient it's not applicable, no? Okay. Okay.
Yes,
So
sir.
that's how you use the my patient management process, specifically in the selection of treatment, the BRCA. No? Okay.
Thank you, sir.
Okay. Did I answer your question?
Yes po, sir.
So any more comment from Wendy? Wendy, do you have any question?
None so far, sir.
Shamil? Shamil, Marie Ang, yeah. Any questions?
No, hindi po siya masyado related sa patient natin, but I just wanna know if yung endoscopic thyroidectomy po ba, since it's only available in St. Luke's and Medical City, so are they also the ones providing the training, or do they send pa doctors to other countries for the training?
I don't know the history, but it most likely started with the local surgeons here. Probably they went abroad for some training, and then when they came back, now they start training people already. No? Or at the moment, probably they're the only ones doing it. No? So baka wala pang training program. No? Okay. Okay. So actually, ano ba yung ano? Okay. I'm trying to see now. You use the term endoscopic. What's T? What's T? What TET? What's T?
Total endoscopic, sir.
Total.
Thyroidectomy.
Total.
Yes, sir.
Okay. So let's just call it endoscopic thyroidectomy. Okay. Okay. So is it different from a procedure that is being done that has been done in PGH? No. So they put a scope through the back of the tongue and then remove the thyroid from that area without putting skin incision. Is that the same?
I believe so, sir. Yung transoral approach po ba yun, sir?
So yung journal is transoral.
No, sir. It included several approach. Merong chest breast,
Axilla.
may axillary, sir.
Ah,
Opo.
Okay.
Merong BABA.
Okay. So inclusive na siya. Inclusive
Yes, sir.
siya. So that yung tinatawag na endoscopic thyroidectomy has been done in PGH. Okay. It's not being done frequently lang. Okay. It's being done. It has been done. No? Okay. Okay. Just for your information. No? Okay, Shamil? Okay. Any more?
Yes. Okay.
Gabi? Gabriel? Okay.
Yes, none so far po, sir.
Okay. Okay. So comment here will be, do you know why there's a higher incidence for recurrent nerve injury in which one? In endoscopic thyroidectomy? Bakit mas mataas? Yung isa, bakit mas mababa yung yung hypocalcemia? Ano ba? Okay. So 2 centimeter tumor, di ba? 2 centimeter nila. So endoscopic, makikita man nila yung recurrent nerve, no? Whether it's endoscopic or open, they have to visualize the recurrent laryngeal nerve, di ba? So I don't know. I don't know. If you don't know, probably I don't know also because I have to know the details. No? Okay. So, but I can surmise that baka they use a lot of cautery there in endoscopic. No? Okay. So sometimes the recurrent laryngeal nerve is affected by the burning of the instrument. No? Baka kaya transient, di ba? Transient lang siya. No? Okay. Now, hypocalcemia, yeah.
Sorry, sir. In the discussion po pala, they said na thermal damage from the ultrasonic scalpel may cause injury to the recurrent laryngeal nerve po.
So, pwede.
Pwede, sir. Yung sinabi niyo po. Pwede po.
Yung sound, yung waves, ultrasound ba yan?
I'm not sure, sir. Pero yung term niyo was ultrasonic scalpel.
Yeah, scalpel. So, but they admit it can cause some injury. Okay.
Yes, sir.
Okay.
Yes, sir. Sir, I'm reading a different study and it said po that the entry point po kasi when they do total endoscopic therapy is near po the nerve po. That's why there's increased risk of damage thermally po.
Entry of the scope. Yan ba?
Yes.
So, saan ang damage doon sa itaas, sa baba? Because the recurrent laryngeal nerve goes up to the larynx. Diba?
Sir, extralaryngeal branch po yung stated po.
Extralaryngeal branch, external laryngeal branch. So, okay. Okay. So baka, yeah, because of the end, sa galing siya sa itaas, no? Whereas yung open, you start from below and then you go up. No? Okay. So you try to avoid the external laryngeal nerve. No? Okay. Okay. How about hypocalcemia? You have hypocalcemia when you have totally removed the 4, at least the average of 4 parathyroids, or you provide ischemia during your manipulation. You did not remove it because malilit lang kasi mga blood vessels going to the hypothyroid, going to the parathyroid, baka nagkaroon ng manipulation, ischemia. No? Okay. So why is it lower in TET? Di ba, TET?
Yes, sir. Sir,
Why?
the study said po na it's because the parathyroid glands are easily identified using the optics of the endoscope.
Mm-hmm. Okay. Kasi it's really difficult to identify parathyroids, even with the open. No? It's hard to recognize. No? Okay. So if they claim that it's easier to identify, paano, paano nila na-identify?
I'm not sure, sir.
Yeah, I don't expect you to answer that, pero mukhang I have to look for the answer. Baka sa endoscopic parang ano lang eh, may lens lang siya eh, di ba?
Na-zoom in po.
Zoom
ba?
lang eh. Baka nasa-zoom lang, no? Okay. 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 And then, of course, cosmetic is always, an advantage of the, wala kasing scar, walang skin incision,
Yes.
no? Okay. Okay. Tumor size, okay. Okay, last comment na lang, heterogeneity. Okay, aside from the, you mentioned about the different tumor factors and other factors, but they did not mention the surgeon factor, did they? Okay.
No,
Surgeon
sir.
is also a factor. Baka may magaling dyan, di ba? Yung iba hindi magaling, di ba? So you cannot
Mhm.
really standardize the competency of the surgeon. Di ba?
Sure.
Okay.
Yes, sir.
Okay. So if there are no more questions, let's leave the journal report.
Thank you, sir.
Okay. So remember the use of BRCA when you choose a particular treatment options. Na? Okay. Okay, let's now have the journal presentation and discussions.
So good morning everyone po. So I will begin po with the case overview. So this is a case of MM, a 22-year-old male rice farmer from Nueva Ecija, consulting for anterior neck masses. Initially noted 4 years prior, gradually increasing in size and number, with no associated hypo or hyperthyroidism symptoms, no dysphagia or odynophagia, no difficulty of breathing, no hoarseness. Recently presenting with globus sensation. So the patient was advised surgery and referred to PGH, hence this admission. Review of systems, past medical history, and personal social history are all unremarkable, with no noted radiation exposure to the head and neck region. Systemic PE were otherwise unremarkable except for the noted palpable neck masses, 2 of which are 6 by 6 by 3 and 4.5 by 4 by 2 centimeters, smooth, fixed, non-tender, and moves with deglutition, and one which is 5.5 by 3.5 by 0.5 centimeters, smooth, movable, non-tender mass that does not move with deglutition. Fine needle aspiration biopsy revealed papillary thyroid carcinoma, and the patient underwent total thyroidectomy last September 19 with good recovery post-operatively. So for full case endorsement, So for full case endorsement, respectfully endorsing patient MM, a 22-year-old married male, Roman Catholic rice farmer from Nueva Ecija, admitted for the chief complaint of bukol sa leeg. 4 years prior to admission, the patient noticed a non-tender mass at the left anterior neck, no noted dysphagia or odynophagia, no difficulty of breathing, no palpitations, no heat or cold intolerance. In the interim, no consultations or interventions were taken. 2 years prior to admission, the mass continued to increase in size, and now with the growth of a new palpable nodule at the left of the initial mass. Still no other associated signs or symptoms. The patient sought consult at a local hospital where he was advised ultrasonography and biopsy of the mass, but the patient was not able to do so and was lost to follow up. The patient drank unrecalled herbal medicine for a short time without resolution. In the interim, the masses continued to gradually grow in size, eventually presenting with globus sensation. Still no dysphagia or odynophagia, no tenderness, no hoarseness. 8 months prior to admission, the patient noticed another left anterior neck mass, which rapidly grew in size in the interim. The patient did not seek consult until 4 months prior to admission, when the patient was able to have an ultrasound taken in a private hospital in Nueva Ecija and was advised surgery. He was then referred to PGH, hence this admission. So the review of systems is generally unremarkable. No hypo or hyperthyroidism symptoms, no palpitations, no heat or cold intolerance. The patient does not have any known comorbidities, no hypertension, diabetes, previous cancers, tuberculosis, or asthma, no known allergies to food or medications, no previous hospitalizations or surgeries, the patient is not vaccinated against COVID-19. The patient is a non-smoker, occasional alcoholic beverage drinker, and denies illicit drug use. He works as a rice farmer in Nueva Ecija with no use of no pesticide use or exposure. There is also no known radiation exposure to the head and neck region. So on September 18, 2022, one day prior to the operation, the patient was seen awake, alert, conversant, and oriented, and not in cardiorespiratory distress. The patient had the following vital signs. So he was normotensive at 110/80 millimeters mercury with normal heart rate and respiratory rate at 89 beats per minute and 16 cycles per minute respectively. He had good oxygen saturations at 98% on room air and was afebrile at 36.0 degrees Celsius. Systemic PE during this time are as follows. So he had anicteric sclerae, pale palpebral conjunctivae, 4x4 millimeters equal and briskly reactive to light pupils, intact direct and consensual light reflex with no RAPD. Intact gross hearing, no sinus tenderness, and no oral cavity masses or discharge. Particular for this examination are the 3 anterior neck masses which were palpated. All had regular borders and no noted skin changes. Now presenting with global sensation. The first mass was 6x6x3 centimeters, smooth fixed non-tender mass and moves with deglutition. The second mass was 4.5x4x2 centimeters, smooth fixed non-tender mass which also moves with deglutition. And the third mass palpated was 5.5x3.5 by 0.5 centimeters, smooth movable non-tender, does not move with deglutition, which is most likely an enlarged level 5B cervical lymph node. The trachea was obscured by the anterior neck masses, no sternal fullness, and the patient had negative Pemberton sign. Other systemic PE findings are unremarkable. Notably for this patient po, laryngoscopy, rhinoscopy, and otoscopy were not done. So here are the actual photos of the anterior neck masses pre-operatively. Next slide, please.
So after gathering all the necessary information from the patient, history, and physical examination, we then incorporate the process of pattern recognition and prevalence to come up with a primary and secondary clinical diagnosis. Next slide. So the algorithm showed this from the American Academy of Otolaryngology, Head and Neck Surgery Clinical Practice Guidelines in the Evaluation of Neck Masses in Adults, which depicts the possible diagnostic approach in evaluating a neck mass in adults based on findings on the initial history and physical examination. So for the clinical diagnosis, the main focus would mostly be on the first 4 levels. Sorry. So exclusion of bacterial and malignant etiologies is initially done based on the patient's clinical profile. So while most neck masses in adults are not infectious, this is done to avoid routine treatment with antibiotics, which may be inappropriate or ineffective in treatment for a neck mass, thus leading to delayed diagnosis of malignancy or serious illnesses. So since the patient's mass growth pattern does not match that of an infectious neck mass, which is a mass developing within a few days or weeks of an upper respiratory or dental infection, trauma, or travel, and does not present with any signs and symptoms of infection such as fever, warmth, erythema, tenderness, and tachycardia, we then consider the possibility of malignancy. So next slide. So for the primary diagnosis for this patient is thyroid malignancy based on multiple suspicious findings that suggest its increased likelihood. So the identified risk factors for this patient are male sex and his young age. So while thyroid nodules, as mentioned earlier, are more common in females with a 3:1 ratio, nodules in males are more likely to be neoplastic, and nodules in the very young, such as those less than 20 years old at presentation of the mass, is also a red flag for thyroid malignancy. For the characteristics of the mass, these are also suggestive of malignancy. So an immobile midline neck mass that moves with deglutition indicates a thyroid source, and the chronicity, continuous enlargement, solid consistency and lack of tenderness of the mass raises the suspicion for malignancy. So the patient is also mostly asymptomatic sans the presence of the globus sensation. So patients with thyroid malignancies are mostly asymptomatic unless their tumor is large enough to cause symptoms due to local infiltration or structure compression. So in this patient, the globus sensation is likely due to the mass effect of the tumor. Also, on physical examination, the patient presented with cervical lymphadenopathy, which is a common feature of thyroid malignancy, particularly in papillary thyroid carcinoma, which commonly metastasizes to the regional lymph nodes. Important to note here, though, is that the major risk factor predisposing to thyroid cancer, which are a history of childhood irradiation to the head and neck and the family history of thyroid cancer, are absent in this patient. Next slide. Sorry. So for our secondary diagnosis, it is for the secondary diagnosis for this patient would be a non-toxic multinodular goiter. So this is also based on the clinical presentation of a painless, gradually enlarging firm neck mass that moves with deglutition in a mostly asymptomatic patient. So here the thyroid enlargement is mostly due to the impaired thyroid hormone synthesis, which would lead to a compensatory rise in the serum TSH. And this would lead to the hypertrophy and hyperplasia of the thyroid follicular cells. So the euthyroid state would also be maintained due to these compensatory changes. So after formulating the primary and secondary diagnosis, we should then give advice to the patient regarding the findings and how we arrived at his clinical impression. So we should note that in the clinical diagnosis, we mostly use pattern recognition in arriving at these impressions.
Good morning. To proceed to the paraclinical diagnostic procedures. Next slide, please. So, to decide on indication of the paraclinical diagnostic procedures, the physician uses two processes: degree of certainty on the primary clinical diagnosis and comparison of the treatment plans for the diagnosis. And just to recall, our primary clinical diagnosis is thyroid malignancy, and secondary clinical diagnosis is non-toxic multinodular goiter. For the clinical diagnosis, the thyroid malignancy has 90% certainty. As our basis for thyroid malignancy, our patient is young male. There is rapid mass growth, obstructive symptom, which is globus sensation, asymptomatic neck mass, presence of cervical lymphadenopathy. Nodules are firm, hard, and fixed. So there is already 90% certainty that we should lean towards thyroid malignancy. And the treatment modality for this is thyroidectomy, which is surgical. For the non-toxic multinodular goiter, the certainty is only 10%, and the treatment modality is iodine supplementation plus lifelong T4 therapy, which are non-surgical modalities, near total or total thyroidectomy, which are surgical. Next slide, please. So these are the laboratory histopathologic imaging studies that we can do. We advise the patient to undergo these procedures as these are all readily available, affordable, and beneficial to the patient with very minimal risk. Also, according to the 2015 ATA guidelines, these are the first three strongly recommended diagnostic tests. So first is serum TSH. It has 76% accuracy of identifying thyroid malignancy. The risk is acceptable because there are no stated risks for this test. The cost is 1,300 and it is readily available. For fine needle aspiration, it has 98% accuracy with acceptable risk. It was noted to be 0.43 risk, which include bleeding as well as destruction of adjacent structures. FNAB is the most accurate and cost-effective method for evaluating thyroid nodules. It costs 800 pesos and it is also readily available and easy to perform. For thyroid sonography, this is done with survey of the cervical lymph nodes. So the benefit is 91% accuracy with acceptable risk because there are also no noted risks for this test. The cost is 850 and it's also readily available. Next. After deciding on the degree of certainty and the primary diagnosis, we need to choose a test to prioritize which has higher benefit to the clinician and patient as well, and that is FNAB. For ultrasound-guided FNAB, patient is placed on supine position with the neck slightly extended. After the lesion is localized, the overlying skin is cleansed with 10% povidone iodine solution and the area is draped. Approximately 1 to 2 ml of 1% lidocaine hydrochloride solution may be injected into the skin and superficial subcutaneous skin tissue at the predetermined site. A 22 to 27 gauge needle is used with an attached 2 to 20 ml syringe. And for the histopathologic study, Papa Nicolau staining is most commonly used for cytologic analysis of thyroid specimens, and it provides the clearest depiction of nuclear chromatin, ground glass nuclei, and nuclear groove characteristics in papillary carcinoma. Next slide, please. The classic pattern of this thyroid malignancy is characterized as papillary structures consisting of many neoplastic follicular epithelial cells with intranuclear cytoplasmic pseudoinclusions, which are shown in arrows in figure A, and samoma bodies, which are pointed in arrows in the arrow of figure B. Next slide. For the interpretation, these are the following diagnostic tests that were advised or that were which the patient had when he was admitted in PGH. FNAB gives us direct diagnosis already, and it showed congruent findings with papillary carcinoma. On the other hand, thyroid function tests, the TSH level lies within normal range while the free T3 is elevated. We can deduce from here that there is subclinical hyperthyroidism, meaning there is hyperfunctioning of the thyroid gland, but there are no clinical manifestations present. Lastly, thyroid ultrasound showed that the right lobe is enlarged with homogeneous parenchymal echo pattern, while the left lobe and isthmus are enlarged with heterogeneous nodular parenchyma with multiple tiny microcalcifications scattered at the cystic spaces. These findings are congruent or similar to findings of thyroid malignancy. Next slide. This algorithm is lifted from 10 to 15 American Thyroid Association management guidelines for evaluation and management of patients with thyroid nodules based on ultrasound pattern and FNAB cytology. For our patient, there is normal TSH level, and when we did thyroid ultrasound, the pattern showed intermediate to high suspicion of malignancy. Upon performing the FNAB, this revealed papillary carcinoma, thus we go to the malignant option, which is suggested to be surgically managed. Next. So this is just an overview of thyroid scoring. This scoring system assesses the risk for malignancy of thyroid nodules. It only means that the higher the thyroid score, higher the risk for malignancy.
For the treatment, Next slide, please. Our primary diagnosis is papillary thyroid carcinoma on the basis of the patient's age, 22-year-old, male sex, presented with 4-year history of gradually enlarging, painless, solid, slightly movable anterior neck mass with globus sensation. Thyroid ultrasound also revealed enlarged gland with the following measurements, and more importantly, the presence of multiple tiny microcalcifications in the left lobe and isthmus is frequently indicative of thyroid cancer. This patient is then advised on pre-treatment diagnosis and the goals of treatments, which will be stated on the next slide. Next slide, please. So our secondary diagnosis is non-toxic multinodular goiter due to the noted signs and symptoms of solid, slightly movable anterior neck mass, globus sensation, and the thyroid ultrasound showing enlarged left lobe, isthmus, and the right lobe. So for the goals of treatment for this case is, next slide, please, is a complete removal of the thyroid gland and resection of the lymph node metastasis to prevent extensive metastatic disease, prevention of laryngeal function, and to prolong survival and improve the quality of life of our patient. So next slide, please. So surgery is the mainstay of therapy for differentiated thyroid cancers. The operative approach depends upon the extent of the disease based on the primary tumor size and the presence of comorbid conditions or prior exposure to radiation. So for tumor less than 1 centimeters without extrathyroidal extension and no lymph nodes, thyroid lobectomy is preferred unless there are other indications to remove contralateral lobe, such as clinically evident thyroid cancer in the contralateral lobe, previous history of head and neck radiation, and strong family history of thyroid cancer. Next, for tumor 1 to 4 centimeters without extrathyroidal extension and no lymph nodes, either a total thyroidectomy or thyroid lobectomy may be done. So total thyroidectomy would be chosen either based on patient preference, the presence of ultrasonographic abnormalities in the contralateral lobe, or on a decision by the treatment team that radioiodine therapy may be beneficial either as adjuvant therapy or to facilitate follow-up. So if the primary tumor is 4 centimeters in diameter or greater, there is extrathyroidal extension of the tumor, or there are metastases to the lymph nodes or distant sites, total thyroidectomy is recommended. It is also recommended and should be performed in all patients with thyroid cancers who have a history of exposure to radiation of the head and neck due to the high rate of tumor recurrence and disease-specific mortality. With all that being said, the case of our patient warrants a total thyroidectomy with modified radical neck dissection. So, next slide, please. Here is a table showing different treatment modalities available for patients diagnosed with papillary thyroid cancer. So for operative treatment modalities, thyroid lobectomy is done again when tumor is less than 1 cm or 1 to 4 cm without extrathyroidal extension with acceptable risk, which costs around 62,000 pesos. And then total thyroidectomy is done for tumors greater than 4 centimeters, again with extrathyroidal extension or distant metastasis, or with the prior history of exposure to radiation with benefits outweighing the risks, amounting to around 62 to 93,000 pesos. Next slide, please. For non-operative modalities, radioactive iodine therapy is usually done for adjuvant therapies with 2 indications. So one is to ablate the residual normal thyroid tissue remaining after thyroidectomy to prevent subsequent de novo thyroid cancer formation in the remnant tissue. And the second indication for RAI is to treat clinically detectable disease that cannot be addressed by surgery. So this costs more or less around 7,280 pesos. Another option is external beam radiation, however, plays a limited but important palliative role for selected situation in differentiated thyroid cancer. The main indication for EBRT include local control of unresectable, locally advanced, macro or microscopic residual disease after thyroidectomy, as well as treatment of symptomatic distant metastatic foci that are RAI non-avid. So yeah, this costs around 11,360 pesos. And lastly, available systemic therapy for advanced thyroid cancer is a tyrosine kinase inhibitor, lenvatinib, which is approved for the treatment of RAI refractory differentiated thyroid cancer. Available preparations are 4 milligram per cup and 10 milligram per cup. However, the needed dose for thyroid cancer is 24 milligram per cup once daily, continued until disease progression or unacceptable toxicity. So this costs more expensive since daily siya. And all rates are based on the PhilHealth procedure case rates and local drugstore for the lenvatinib. So here we advise the patient on option and allow him to decide. So once there's an agreement, we proceed to secure the written informed consent and do the procedure. So the operation was scheduled last September 19, 2022 from 7:30 to 3:30 p.m. Again, the procedure was total thyroidectomy with modified radical neck dissection left. So before the surgery, patient underwent endocrinology clearance, and then anesthetic and surgical plans were explained to the patient. So once risks were understood and acceptable, informed consent was secured. So the surgery was started by Dr. De La Fuente, assisted by Dr. Dofitas, Dr. Di Maano, and Dr. De Jesus. I was also the intern assist for this surgery. So uh, this is the gist of what took place during the operation. So the patient was placed in supine position. General anesthesia was induced, and the patient was then intubated. A shoulder roll was placed between the neck and the shoulders, and the neck was hyperextended, and the head laterally rotated to the right to expose the surgical field. So the field was prepped with povidone iodine solution, and sterile drapes were applied. A hockey stick incision was made, and a subplatysmal flap was created via electrocautery and sutured to the drapes for exposure. So the surgeon began with the neck dissection of the lateral compartment, starting with identification of the sternocleidomastoid to determine the posterior triangle, and dissected the level 5 lymph nodes. The spinal accessory nerve was also identified, separated, and preserved from the lymphatic tissues. Again, the SCM was separated from the fascia and lymphatic tissues to permit visualization of the structures underneath. The omohyoid muscle was also identified and dissected to expose the internal jugular vein. Once the internal jugular vein was identified, it was separated from its surrounding fascia and the lymphatic tissues. Small vessel branches of the internal jugular vein were ligated to prevent bleeding, and further dissection was made until the levels 2, 3, 4, and 5 lymphatic tissues were separated from all the structures. So after the lymph node excision, total thyroidectomy was started by separating the sternohyoid to expose the anterior surface of the thyroid gland. The strap muscles were then retracted and separated from the thyroid gland. And once the thyroid gland was exposed, the superior pole of the left lobe was separated underneath using a retracting device until it is mobilized. And when the gland was mobilized medially, the recurrent laryngeal nerve was identified and carefully preserved. So once the surface of the trachea was identified, the isthmus was separated from the trachea and subsequently dissected the right lobe. So after all the tissues were dissected, a Valsalva procedure was performed and hemostasis was done. The strap muscles were then sutured back, and sutured subplatysmal flap from the drape were removed. And the platysma in the skin was approximated and was closed using subcuticular suture techniques. So next slide, please. So before you is an image of the resected thyroid gland with the left lobe solid and large, measuring 4 by 4 centimeters, with enlarged isthmus and the right lobe on next for the label there. So that's the left lobe, isthmus, and the right lobe. Next slide, please. So the lymphatic tissues were dissected were next slide, were level 2, upper jugular, level 3, middle jugular, level 4, lower jugular, and level 5, posterior triangle cervical lymph nodes, which were all enlarged. Next slide, please. So here are the following images before closing, showing on the left that the left internal jugular vein was preserved. Next. There. And as well as the left recurrent laryngeal nerve. Next slide, please. So immediately after surgery, the patient was hooked to 5% dextrose, 1 liter, 110 ml per hour at the left metacarpal vein, oxygen at 4 to 6 lpm via face mask. Patient was placed in semi-fowler position, ensured adequate pain control. So the patient was given paracetamol 600 milligram IV every 6 hours, celecoxib 200 milligram twice a day for 3 days, nalbuphine 10 milligram IV every 8 hours for breakthrough pain, and ondansetron 4 milligram IV every 12 hours for nausea and vomiting. So serum calcium albumin was requested 6 hours and 24 hours post-op, and the patient was also started with calcium and vitamin D 600 milligram and 400 IU tablet, 2 tablets twice a day, and levothyroxine 125 microgram tablet once daily, 1 hour before breakfast. Then patient is monitored for pain control, post-operative hematoma, dysphagia, dysphonia, dyspnea, and signs of hypocalcemia such as Shostak sign, perioral numbness, extremity numbness, rigidity, and seizures. So shown before you is the TNM classification of the thyroid tumors lifted from Schwartz. So the staging system most often used for thyroid cancer is the American Joint Committee on Cancer TNM system, which is based on 3 components. So the extent or size of the tumor, or the spread to nearby lymph nodes, or the spread to distant sites or organs. First, we consider the age at diagnosis, since younger people have a low likelihood of dying from differentiated thyroid cancer. So all people younger than 55 years old with these cancers are stage 1 if they have no distant spread, and stage 2 if they have distant spread. So in the case of our patient is 22-year-old at diagnosis, with a T3A greater than 4 cm, limited to the thyroid, N1B metastasis to unilateral lateral lymph node 2, 3, 4, and 5, and M0 no distant metastasis. So patient is stage 1 papillary thyroid cancer.
So for this patient po, the final diagnosis for this patient is papillary thyroid carcinoma stage 1. So in the general population, thyroid cancer screening is not routinely performed, and there is no single test that can be used for screening asymptomatic individuals with average risk. So risk factors of thyroid carcinoma include sex, with females more likely, family history of thyroid cancers, and radiation exposure of the thyroid gland during childhood. If any of these risk factors are present and the patient is deemed high risk for thyroid malignancies, then regular clinic visits, periodic blood tests, or genetic testing may detect thyroid carcinoma in the early stages, although these might not be very cost effective. For this patient, all the aforementioned risk factors were not present based on history taking. Thus, regular early screening would not have been effective or cost efficient for prevention or early detection. Nevertheless, we can still encourage the patient to develop good health-seeking behavior. So based on history, we recall that the mass was initially detected 4 years prior to admission, yet no consult or intervention was taken within the first 2 years. And after his first consultation at the local hospital, he was again lost to follow-up. So there is room for improvement for his health-seeking behavior, which we can improve with proper patient education regarding his disease and involving the patient in his own healthcare decisions. Generally, papillary thyroid carcinoma patients have good prognosis. So the Surveillance Epidemiology and End Results Program, or SEER, categorized survival rates of thyroid carcinoma based on extent of spread, with localized having no spread outside the thyroid, regional having spread to adjacent structures, and distant having spread to distant organs. For regional papillary thyroid carcinoma, which our patient has, the 5-year relative survival rate is 98 to 99%. However, recurrence is a common concern among papillary thyroid carcinoma patients. The following are factors for high risk for recurrence. So, lymph node metastasis, histologic variant, tumor size, extrathyroidal extension, extranodal extension, male sex, and age above 45 years old at time of diagnosis. Hence, we must inform the patient to have regular clinic visits in order to catch recurrence early should it occur. And lastly, for health maintenance, we can advise the patient to eat a healthy and balanced diet, wear proper personal protective equipment while working, and to update his vaccination records, especially since he is not yet vaccinated against COVID-19. Next slide. Sorry, sir. That was the last slide for our case presentation.
Okay. Okay. Questions? Comments from those who did not present? Patricia? Any additions?
Sir, none that I can think of po now, sir. I think they were comprehensive with their presentation.
Okay. Jojo Mar?
Also, sir, none.
Sila pa nag-present. Abraham?
Hi, sir.
None?
I think I was just also curious if there is, and we've also talked about this, if there is a clinical way of possibly suspecting the pathology of the cancer or thyroid cancer based on the clinical information, aside from the prevalence itself, siguro, sir. And secondly would be, I was also curious yung cutoff na 4 centimeters, sir. Why 4 centimeters and not, yung sa 1 to 4, why 1, why 4, and not up or below? Or for sure may basis yung studies. Pero,
Again, 1.
Dun po sa cutoff na which Shamil presented, yung mga, di po ba,
1 to 4.
Opo, 1 and 4.
More than
nag-use
1,
lang
more
po.
than 1. 1 and more than, less than 1 and more than 1. Okay.
2 to 4 and then, opo. Yes, sir. Parang yung basis lang of the size.
Okay. So I'll try to answer your questions, your concerns. Okay. Okay, but first of all, as I was listening to your presentation, I'm also thinking about the things, parang ano, okay, reflection, just sort of a reflection after so many years of teaching. Okay. Okay. I would classify physicians into 2. 1, your students who have to take the board exam. Okay. Students who still have to take the board exam to be certified. Okay, whatever. Okay. Physician medical exam, or yung iba naman, residency, they have to take the certifying board exam for the specialty, right? Okay. And then the other category is the certainly practitioner already, who can go on his own already. Okay. So at your stage, okay, just like what you did, you gather a lot of informations, no? So you try to read a lot of things. No? Okay lang yan. Okay, we just have to accept that because you have the testing requirement. Okay? Because you don't know what's gonna come out in your test, and you know that the examiners have different ways of putting out questions. No, you can never predict. No, okay. So there's no standardized curriculum for the test. Di ba? Kanya-kanya yan eh. Kanya-kanyang examiners, banat ng examiners yan eh. Di ba? Okay. And the answers usually, hindi naman siya absolute. Di ba? Okay. That's why there's no such thing as, they just, they use the bell curve. Usually they use the bell curve for the passing. Di ba? Okay. Now, if you are the practitioner already, no, after hearing or reading all the information that you get from the internet, from the conventions, no, yung mga ganon, no, it's time for you to make a decision, no, what you think are really useful to your patient, no, okay. So even those the clinical practice guidelines are very, very popular, no, but even those guidelines doesn't mean that you have to. They're just guidelines. You don't have to really follow. Okay, so in the end, you think of what is best for your patient, for a particular patient. No? So this is what we call patient-centered care management. Okay, so each patient will be managed differently. Okay, based on their belief, based on their psychosocial concerns, etc. Okay, so sa inyo, at the moment, okay, okay lang yan. You just try to absorb as much as you can. No, okay, because you have to take the test. No, you have to pass the test. But at this time, I'm already introducing to you. That's why most likely I like to teach you. This is the best time to teach you year level 7, di ba? Kaysa yung patient management process will be the best time to teach you at this level. No? So you can more or less apply it. No? Okay. If I teach this patient management process, which I used to lecture on the 2nd year, 3rd year before, nawawala along the way. Di ba? Nawawala along the way. Okay? Because natatabunan ng ibang mindset ng ibang consultants, ibang teachers, no? Iba-iba. No? Okay? So try to get the, yung sa akin naman, I just teach the process. No? It's a practice guidelines by itself but I use the process, no, to guide you. No, I don't say this is the antibiotics for this one. This is the treatment for this one. Yung mga practice guidelines, diba? Very absolute, diba? Okay. But what I'm teaching you is the process of selection of decision making. No, okay. Okay. To your question, how do you how should I go about it? Okay, probably I'll go through the case itself, now summarize it a little bit, and then probably most likely I will touch on your questions, Abraham. Okay, so we start with how old is the patient? How old?
22 po, sir.
22-year-old male presenting with a neck mass. Okay. So if you were the one treating this patient, you saw this patient for the first time, no? So right away, makikita mo na kasi ambulant naman siya, di ba? Okay. So makikita mo yung mass niya nasa front of the neck. Okay. That's why you call anterior neck mass. Okay. And then the moment you have something on the neck, you start thinking, is this thyroid? Because that's the most common organ involved there. Okay. Although there are a lot of central organs there. Okay. And then we also think whether these are lymph nodes on the side of the neck. Okay. Okay. Then what you can do is go directly and palpate the patient. No? And while palpating the patient, you can ask questions. You get your history para pertinent. Kasi iniisip mo na, is this thyroid kaya ito o kaya lymph nodes? Diba? Kasi yung drawing that you gave me, malaki na siya, di ba? 4 centimeters and then halos occupying the front of the neck, di ba? Okay. So, yung drawing ninyo, I was looking at your drawing. Yung drawing nyo, kasama ba yung right side? The illustration that you gave me, kasi kasama yung right side eh. But in reality, it's only the left side that's what's involved. No? Okay. So, pero pag tingin ninyo, involved ba yung right side, the whole neck?
Sir, when we palpated po,
Hindi, yung tingin lang, tingin. Just by inspection. The whole,
no, mukhang hindi po, sir.
mukhang hindi. Naka-confine sa left side? Sa tingin lang. You show me a picture, di ba?
Yes po, sir.
Oh.
Sa tingin lang, sir, parang
Buong neck? Kasi malaki na eh. Lumalampas ng midline to the other side. Tama?
Yes.
Okay. Based on the picture that you sent me. Okay. So you don't, basta thyroid, alam mo, no? You don't know which side, diba? Because you have not palpated the patient. Okay. Then you go ahead and palpate the patient. No? Then determine whether it moves with deglutition, yung sa gitna. No? If it moves with deglutition, thyroid kagad yung iisipin mo. Okay? Okay. Then, if there are masses which do not move with deglutition, no, example dun sa left side of the neck, then you think of lymph nodes. Okay? That's a clue. And then when you palpate the thyroid gland, you determine, number one, which side is involved. No? As we know, there's a right and a left. Okay? So you determine, is the right side involved or the left lobe is involved? No? Okay. So yun sa inyo, pagtingin ninyo, parang occupied na yung right side, di ba? Okay. Okay. So, but when you palpate, no, you can, I'm not going to say it's easy, sometimes it's difficult, but you try to palpate the left lobe and the right lobe. No? If you can palpate use the trachea as your reference, okay? So if there is a mass along one side of the trachea, that means it's one side, no? Okay. If it's there are two palpable bulging on both sides of the trachea, then you can say that most likely the right and the left lobe are involved. Okay? So by inspection, pag tingin mo, kung talagang left lobe lang involved, it could mean that the trachea was deviated. Natulak yung trachea to the other side. Okay, is that the case? Was that the case? Was that the case? Were
Sir,
you able to determine?
The trachea na po.
Uh-huh.
Sir, it was obscured na po in the, we were only able to trace if it was midline from the top po. Pero when it came near the sternum na po, it was already obscured. We were unable to palpate if it was still midline po, sir.
Okay. Anyway, okay, as I said, you try your best. Now you try to determine which is which. Now, okay, kasi kung right and left lobes are involved, automatically total thyroidectomy if you have to do an operation. If one lobe is only involved, no, there's a possibility that you just remove the one side, diba? Okay. So that's an important information that you have to get on your physical exam, no? Okay. So then after that, you determine the other characteristics of the mass, which now I will try to answer your question now, Abraham. Okay. So the mass, so it moves with deglutition. Okay. And then the mass is solid. Okay. Of course, you measure the size later on, no? Okay. Then the mass is solid. Okay. When you say there are instances in which the mass is cystic. Okay. Okay. So if the mass is cystic, there's a tendency for you to think that it's benign. If it's solid, na, it could mean anything. Could be malignant, pwede benign pa rin. Okay? But the moment it's cystic, you start thinking of benign. That's your clue. Okay? So, etong pasyente nito, solid. So, wala ka pang other information that will tilt the balance towards benign or malignant. Okay? And then, so when you talk about solid and cystic, the word that I use there is the nature of the mass, to contrast it with consistency. Kasi consistency will be hard, soft, firm, etc. Di ba? Okay. So you first determine whether it's cystic or solid, the nature of the mass, whether it's cystic or solid, and then the consistency, whether it's hard or not hard. Okay. Pwedeng hard and non-hard na lang. Kasi if you ask 10 consultants, even consultants to determine is it hard or not hard, there's only about 20% concurrency. Iba-iba kasi yung feel nila. No? Okay. So but you use hard and non-hard, usually 90% concurrency na yan. No? Okay. And what's more important is the hardness of the mass. The hardness of the mass will make you suspect malignancy. Okay. Confirm or soft, it doesn't mean anything. Walang implication doon. No? Okay. And then fixation. Okay. There are two types of fixation. Okay. So when you ask, kasi if it's thyroid, when you ask the patient to swallow, it moves, di ba? Up and down. Okay. You think it's not fixed. But if you stabilize the trachea, huwag mong papagalawin trachea, then you try to move the mass over the trachea. Ibig sabihin, kung nakadikit yan sa trachea, hindi gagalaw yon. So the trachea will move with it. So that's the kind of fixation. No? Usually it's seen in yung mga advanced cancer, no? Pag-fix, or yung mga anaplastic carcinoma, no? Ganon, no? Okay. But if it's movable, so the other type of fixation, it moves with deglutition kasi nakadikit siya, no? O kahit na i-fix mo yung trachea, galawin mo, gumagalaw, no? Okay. So that's not fixed. Okay. So the other type of fixation, whether it's fixed to the skin, overlying skin, no? Okay. So fixation to the mass of the mass is another clue for cancer. Okay. And then lymph nodes. Lymph nodes. Okay. If there are lymph nodes, you start thinking of cancer. Okay. So, and then are there signs of other associated hoarseness of voice? Na? Okay. Kung wala, doesn't mean anything. Okay. Pero pag meron, you suspect cancer. Okay. So a mass on the sinong nag-present ng algorithm? The algorithm by the one with bacteria.
Sir, si Gabby po.
Gabby.
Yes po.
Sorry.
But sir, she got disconnected. She's trying to reconnect.
Wala si Gabby. Okay.
Sir, nawala lang po. It's like
Okay.
for a few minutes.
Okay, what I want to say is that there are a lot of algorithms because there are a lot of things that you will be able to read in the journals, iba-iba, na? Okay. Kung sa akin, iba rin ang approach ko, di ba? Okay. So my approach is that if there is a mass, okay, kasi infection, no, alam mo na kagad, di ba? Whether if there is a sign of inflammations, no, then like fever, like tenderness, like pus, no, then start thinking of thyroiditis, acute abscess, di ba? Okay, but that's not very common, no? Okay, so after practically you can disregard it. You just focus on whether if there is a lump, whether it's benign or malignant, no? Okay, then the way to approach is you look for signs of malignancy first. Okay, if you don't have any signs of malignancy, those that I mentioned, no, hard, okay, fixed with lymph nodes, with hoarseness of voice. Okay. So the moment you have any one, just one of them, okay, you suspect malignancy already. Okay, thyroid malignancy. Okay. Now, kung wala, then most likely it's benign, most likely. But then you still try to look for signs of benignity. If the mass is cystic, solitary lang, then benign right away. Na? Okay. Other clue that it's benign is that when you have multiple nodules na maliliit, multiple nodules, na? Okay. So walang lymph nodes, no fixation, multiple nodules, okay, not hard. No, the chances are it's MCAG. It's multiple colloid adenomatous goiter. Okay, get it? Now, yung benign conditions with thyroid gland will be, it could be a colloid cyst, solitary nodule that is cystic. Pagkapa mo, nadidepress, di ba? Buwabaon, no? And then multiple colloid adenomatous goiter, that's another one. Now, multiple nodules, whether on one side of the thyroid lobe or both sides of the thyroid lobe, or there's a mass there with no signs of malignancy, pero confined to one lobe, you can say that's a colloid adenomatous nodule. Yung kanina, colloid cyst, it contains fluid lang talaga. Yung isa naman, it's a combination of colloid fluid and adenomatous element. That's why it's colloid adenomatous nodule, one nodule. No? Okay. And then if there are multiple, then you call it MCAG. No? Multiple colloid adenomatous goiter. Okay. And then of course the others, there's a lot of other benign conditions like follicular adenoma, follicular adenoma, but it's hard to differentiate it from colloid adenomatous nodule. Pareho lang consistency. No? So you don't give a diagnosis of follicular adenoma anymore because based on prevalence, mas common yung colloid adenomatous nodule. Okay? So you just, kung lalabas ng diagnosis, kung lalabas ay follicular adenoma, it's from your pathologist already. No? But clinically, you don't make such a diagnosis. No? Okay? Okay? So, by the way, before I forget, yung secondary diagnosis ninyo, somebody mentioned about nodular non-toxic. What's the term that you use?
Goiter.
Non-toxic multinodular goiter, sir.
Non-toxic nodular goiter, di ba? Okay.
Yes.
So where did you get that term? Where did you get that term? From WHO ICD?
Sir, from Harrison po, it was stated that there are two types of non-toxic goiter po. From one is diffuse and second is multinodular po.
Okay. That's true. Pero what is, kasi it's a clinical classification eh. For me, non-toxic means the patient is not hyperthyroid. Okay.
Yes, sir.
And then nodular goiter, there's a nodule. Okay. By itself, it's not a specific diagnosis. Get it? Yan ang malaking confusion in the world ngayon. I was looking at the ICD-10, wala silang multiple colloid adenomatous goiter. Okay. So there's such a thing as when you get the histopath report of patients being operated on, there's usually a report of multiple colloid adenomatous goiter. That's a specific condition. Okay. So meaning you have multiple nodules, and then you have a nodule which contains colloid fluid. When you say colloid, usually fluid yon, diba? And then adenoma, usually solid element, and then goiter. Okay. If it's one nodule lang, no, but it consists of colloid and adenomatous element, we just call it colloid adenomatous nodule. Or some pathologists will call it colloid adenoma. No? Okay. So these things, I got it from actual experience, from our pathologists giving me the diagnosis. That's why I tap on it. No? Pero yung sa literature, magulo eh. No? Magulo sa literature. No? So when you say nodular, non-toxic nodular goiter, it's a clinical classification, okay? Because you also have a diffuse non-toxic goiter, okay? Diffuse non-toxic goiter will be represented by the endemic goiter, iron deficiency goiter, and also the diffuse colloid adenomatous goiter, yung starting point ng colloid goiter. No? That's a starting point. Okay. Okay, yung colloid adenomatous goiter usually starts with diffuse, then nodules, colloid cysts or colloid adenomatous nodules or multiple colloid adenomatous nodules. Okay. So remember when you examine a patient with a thyroid gland, you can use this fourth classification. It helps you now, but it's not. You don't stop there now. So is it diffuse? Is it nodular? Okay. Then after that, if it's diffuse, is it toxic or non-toxic? If it's nodular, is it toxic, non-toxic? Okay. So, okay, I want to give you some information which you don't probably read, you don't probably encounter in your classroom. When you say diffuse, as I remember, you mentioned about smoothness of the mass on your di ba? Okay. So, diffuse goiter is defined as, that's the baseline definition. There are two lobes of the thyroid gland, main lobe. If the two lobes are almost symmetrically enlarged, then you call that diffuse. Okay. Don't mistake it from the smoothness of the surface. Okay. That's a common mistake. No? Okay. If there is let's say one lobe is enlarged and it's smooth now on the surface, you call that nodular already. Okay. Because it deviates from the baseline, our baseline definition of two lobes are almost symmetrically enlarged. Yan ang diffuse goiter. Okay. So, and then after that, anything that's does not fit into that definition is nodular. Okay. Okay. Yung mga bukol-bukol, siguradong nodules na yun, no? Pero if there is one nodule there on one side of the thyroid gland, one lobe, and then smooth on surface, you call that nodular goiter already. Okay? Kahit na smooth siya, pag kinat mo, may isang bukol sa loob yun. Na? Okay? Then toxic, non-toxic. Okay? Toxic means hyperthyroid, signs of hyperthyroid. And then non-toxic could either be hypothyroid or euthyroid. Okay? So, and then what are the signs for hyperthyroid? Ang pinaka-basic signs of hyperthyroid, you have diffuse goiter, usually, and then the minimum is the pulse rate. Now you take the pulse rate. If the patient is tachycardic, you start suspecting diffuse toxic goiter. All the more you suspect diffuse toxic goiter or hyperthyroidism, if there is exophthalmos, if there is tremors, okay? Okay. Pero yung minimum, pinaka-early stage, you look at the heart rate. Heart rate ay to consider ninyo, no? So make sure when you examine the patient with a thyroid problem, aside from palpating the neck, you have to get the pulse rate, no? Okay. So clinical classification: diffuse toxic goiter, diffuse non-toxic goiter, and then nodular toxic, nodular non-toxic. Among the four, ang pinaka least common is the nodular toxic. Okay? And then, ang pinaka-common, yung mga nodular toxic goiter, nodular non-toxic goiter. Okay? So in the nodular non-toxic goiter, that's the time you differentiate, is it cancer or not? Okay, nodules na? Okay. So in the diffuse one, you have to think about the thyroid function, whether it's hyperthyroid or non-hyperthyroid. No? Okay. So in the nodular non-toxic goiter, benign, malignant, there are several entities there. You have the cancer itself. Then for the benign one, you have the colloid cyst, you have the colloid adenomatous nodule, you have the multiple colloid adenomatous goiter. Then you have the chronic thyroiditis, yung chronic na, yung matitigas na, okay. It's actually a form of infection, but it's autoimmune, di ba? Okay. Then of course, baka may abscess, na, ganon. Abscess is another one, but it's very rare. Thyroid abscess is very rare, na, okay. And then, of course, you have the follicular adenoma, papillary adenoma, but as I said, it's in the list, but you don't suspect it clinically. There's no basis for that. Kasi when you make a diagnosis for a particular patient, you're making an educated guess. Di ba? Educated guess, saka kung minsan parang may bet kayo with another person. If you think that nodular colloid adenomatous nodule is 90% more common than follicular adenoma, hindi ka magbebet sa follicular adenoma. Di ba? It's very rare. Okay? Okay? So that's how you try to evaluate the patient, no? Clinically, right away. And then, yung type of cancer, you can use the clinical data to suspect the type of cancer, even without the histopath pa. Okay? You know that papillary cancer usually spread through the lymph nodes. Okay? Follicular cancer usually spread through the bloodstream. Okay? Medullary cancer, very rare sa atin. So it can be bought. Okay? And then anaplastic carcinoma, usually may pattern dyan. It's talagang malaking-malaki. Okay? Fast-growing. Elderly patient. At in a few months, sinasakal na yun. Na? Okay? So that's anaplastic. Na? Okay? Okay. So if you have a patient with a thyroid mass, regardless of the consistency, regardless of the mobility, but you have neck nodes, you start thinking of papillary CA. Okay, as I said, only one sign is enough for you to suspect a particular diagnosis. If you have a thyroid mass, malambot, hindi matigas, walang fixation, but you have a mass here sa skull. No? It's not, sabihin natin, it's not exostosis. No? Okay. So it's a mass there that most likely involves the skull. Then you think of, and the patient is not having difficulty of breathing. Kasi the moment patient is having difficulty of breathing, anaplastic yung isipin mo. Diba? Okay. But in that particular case, the patient is symptomatic, wala siyang masyadong difficulty of breathing, no? And then you have a mass there, you have a mass in the neck, you think of follicular carcinoma. Okay. So just by clinical data, you're able to make a very specific diagnosis. No? Okay. Did I answer your question, Abraham?
Yes, sir, and more. Thank you, sir.
Okay. So in that particular patient, you have a neck mass, and then you apply it, no? So papillary CA, suspect mo right away, di ba? Okay. So anong differentials mo? As we said, there's no such thing as 100% certainty, di ba? Okay. Up to 99 lang or 99.9, ganun lang. Hindi pwedeng 100%. Na? Okay. So if you have that pattern, malaki. Fix ba yun? Fix yung mass? Fix ang mass? Is the mass fixed?
Yes po, sir.
Okay.
It felt fixed po.
So lift neck node on one side and then fix. Now you think of thyroid cancer. You think of papillary cancer. Okay. So your degree of certainty is actually more than 90%. Okay. So later on, I'm going to discuss yung how to quantitate the degree of certainty. Mamaya, ha? Hindi nyo nababasa yan eh. Wala kayong nababasa dyan. Okay. Okay, but thank you for your effort to make an estimate. Okay. Okay. So what will be your 1% or 10%? Yung MCA GBAP, does it present with lymph nodes? Usually
No, sir.
wala, di ba? So as much as possible, don't put it as your secondary diagnosis. Di ba? So you think of another one that could kahit na rare. Okay. So TB, very rare, pwede, di ba? TB
Yes, sir.
from the thyroid going to the, okay, or lymphoma going to the thyroid, to the neck nodes, no? Ganon, no? Okay.
Yes, sir.
So that will be your secondary. Kung 1% lang, pero wag mo nang i-explain sa pasyente. Sabihin mo lang 99% papillary na yan. Maguguluhan lang sila. No? That's for your own consumption lang naman. Yung 1%, 2% could be something else. No? Okay? Okay. Now, after that, a degree of certainty. Okay. At the moment, okay, first of all, let me ask you, your interns, now you're seeing patients. Okay. Did you experience ito yung sinasabi ko, when you come out with a diagnosis, siya nga ba ito o ito? Siya nga ba ito o ito? Di ba? Kung minsan, nagtatalo pa kayo sa sarili ninyo, ay, mas sigurado ako ganito. No? Okay? So, in a way, you're trying to quantitate it. It's not 50-50. Di ba? It's not 50-50. No? So, in trying to make a diagnosis, you cannot settle for 50-50. You have to go for either 60, 40, 70, 30, no? 80, 20, ganon, no? Okay. So it's either, kasi you're talking about primary diagnosis, it should be more than 50%. No? Walang 50-50 dyan. It's an educated guess. No? Now, at the moment, there's no such studies on mahirap kasing gawin yan. Na? You quantitate the degree of certainty if these are the symptoms present. Na? Wala yan. Wala sa libro. I've been looking for it for the past 20 years. Wala. Na? Okay. Because I made this patient management process algorithm as early as 1995. Na? I'm teaching this all the way na. Okay. Up to now. Na? Okay. So, what you can do is just based on your subjective experience probability. Okay, there's such thing as subjective probability and objective probability. Okay, accepted yan sa literature. No? Okay, so subjective means based on your experience, what do you think is the frequency? No? Okay, nobody can fault you for that. No? Okay, okay. Now you can reinforce this by ito yung trick dyan, no? If you make a diagnosis based on the signs, signs are more reliable than symptoms, right? Okay. If you make your diagnosis based on the signs, and then this is not contradicted by symptoms or reinforced by the symptoms, and then this is not contradicted by the frequency, the prevalence process, no? Then you can say that you are quite certain. Okay. Get it? Okay. Yung quite certain, it's usually, I just put it at 90 kasi based on yung mga statistics natin, 90% probability, no? Okay, 95%, no? Yung mga t-test, yung mga ganon, di ba? Okay. Okay. And then all the tests usually, if it's more than 90%, usually acceptable yan. No? If it's less than 90%, usually not acceptable yung mga tests, di ba? Okay. So that's the rule that I made for myself. No? Anyway, I'm trying to impart to you. If you base it on this, as I said, sign is more reliable than symptoms, and the least is the prevalence. Okay. Kasi if you have a thyroid mass, na sinabi mo ng okay, most likely it's benign. So you're using prevalence because 90% or 80% of thyroid mass, regardless of the features, characteristics, is benign. Tatama ka doon if you make a bet. Diba? So using prevalence. Na? But if you add more data or more information, sabihin natin hard, this particular patient is hard, it's fixed, there's lymph node. No? Okay, you have already 3 signs of malignancy. No? Okay, then you can put it at 99, 98%. No? More than 90%, you're quite sure. Okay. Okay. Are there symptoms that will contraindicate yung that will contradict the diagnosis? Wala in this particular patient. Wala, di ba? Okay. If you base it on symptoms, mas mababa. Usually less than 90. Okay. Yung globus sensation, if you just, may globus sensation siya at may thyroid siya. If you make a diagnosis, what it will be? Not certain, di ba? Non-specific kasi yan eh. Diba? Okay. Okay. So may hierarchy, signs, symptoms, prevalence. Okay. So you always look for the signs first. Kung walang signs, you're left with symptoms and prevalence already. No? But usually not certain yon. No? Okay. Okay. How do you apply this particular teaching in other cases. Sa breast mass, okay? Kung yung mass is, you have a 20-year-old, 25-year-old female with a mass on the left breast, hard, okay, hard, with lymph nodes, 25 lang ito, hard lymph nodes. So what will be your educated guess? Given that limited data muna. Hard mass with lymph nodes on the same side. Anybody?
Sir, it could be primary na breast cancer or breast metastasis from, sorry, wala pala information yata sa thyroid. Or in relation to thyroid po ba?
Wala. A patient with the breast, walang thyroid.
Ay, sorry, sir.
Test, ina-extend ko lang application what I taught you. A female patient with a breast mass, okay, on one side, left side, and then hard mass, and then you have lymph node metastasis on the axilla. So right away, you think of breast cancer. No?
Yes, sir.
Okay. Huwag mo nang i-factor in yung age niya. Di ba? So you're relying on the signs. Okay? Okay? So kung wala namang signs of malignancy, and then you have a well-defined border, not movable, you think of benign, di ba? Fibroadenoma, di ba? Ganon. So those are the things that you have to consider. You look for the signs and rely on the signs more. Then you look for symptoms, okay? Then rely on use the symptoms to complement your signs, and then the prevalence. Okay. Okay, going back to the thyroid now, yung 98%. Okay, bakit? So the next question is, do you need a paraclinical diagnostic procedure? Yan, okay. So if you're quite certain, 99%, you actually don't need. So in clinical practice, I don't do, but if you're going for the test, okay, you have to know all the various diagnostic tests that can be done, and then also think of the mindset of your examiners. Kasi nagre-review class kayo before any let's say, certifying exam, di ba? Titingnan nyo kung ano bang gusto ng mga examiners ang sagot, di ba? Okay. So if it's 99% na popular CA, do you need a paraclinical? No, di ba? Okay. Now, if it's yes, now you have to justify it. Now, okay. So actually, you can go right ahead and operate on this patient. Okay. Suppose it's 1%, it's not malignant. Pero the treatment is still the same. Tatanggalin mo rin kasi malaki, di ba? May lymph node. So the treatment plan will be the same, whether it's malignant or non-malignant. Then you can go ahead and operate without any diagnostic procedure, based on clinical lang. Okay. Now, suppose you're not sure, okay? Nobody can fault you if you're not sure because sometimes nagkakaiba yung level of expertise, di ba? Okay, ng physicians, So if you say you're not quite sure, okay lang sa akin, Okay, I respect your level of expertise, experience, You say, I need more, okay? So what will be your options? I saw in your table, bakit merong TSH? Tama? May TSH ka dyan. Then you have your ultrasound. Then you also have your needle biopsy. Kailangan pa ba yung TSH?
Yes, sir.
Why?
Para this will tell us to do radioactive iodine scan, sir. If hyperthyroid po, rise scan po. Pag po euthyroid or hypothyroid po, pwede pong FNAP.
Saan mo nabasa yan?
Dun sa algorithm po, sir, ng ATA guidelines.
American Thyroid Association?
Yes, sir.
Okay. So what do you think, kayo? Kasi the process here is like this. You're suspecting thyroid cancer based on your clinical, di ba? Okay. So you want to firm it up, let's say 99, you want to firm it up to 99.9% now. Okay. Or you started with 90%. Okay. I respect your 90%. Sabihin natin, you want to bring it up to 99% now before the treatment. So what are the diagnostic tests that will firm it up? In diagnosis, serum TSH, I don't think it will help.
Yes, sir. It will not help po if we're that certain na po.
It's a thyroid function, di ba? Okay. So
Yes,
another
sir.
issue here, common issue in the society, in the community, take note of this, part of our teaching is you have to know what's happening in life, in the real life. No? The thyroid function test is the cajon routine. Notice nyo no, in your practice? A lot of them are not necessary. Okay, so added cost to the patient, added use of yung mga resources, limited resources. No? So if you are not suspecting hyperthyroid, if you're not suspecting hypothyroid, you don't need those thyroid function tests. Okay, especially if you have a nodule, no, papillary cancer, okay, and then your pulse rate is less than 90 per minute, no, then you don't need your thyroid function test. No? So that's a common issue that I want to raise. No? Okay. But I cannot stop this practice. Mahirap itanggal yung practice niya. No? Okay. Okay. So yung tinatawag na low value diagnostic test. It's consuming a lot of our resources. No? Not only from the patients, but also the hospital resources. No? Okay. So we are left with ultrasound and FNAB. Okay, kung di kailangan serum TSH. No? So which one will be better?
FNAB would be better po, sir, as this
Okay.
is cost-effective po and more specific.
Okay. So kasi yung FNAB direct exam yon, di ba? You get the direct sample. Okay? So logically mas maganda. And then ultrasound indirect imaging lang yon, ini-image lang, na? Okay? And then in terms of risk, when you put the risk, so you tell the patients this is how you tell the patients, no? You have these options, ultrasound, gagawin natin, or FMAB, no? Okay. Then tell them the benefit. The benefit, you direct, and then if FMAB, you do it, you have more than 90%. Nilagay mo 98, di ba? Okay. Where did you get that data? 98, maganda yun. So
Sir, I think in NCBI po.
Mamaya, bigay mo sa akin source, ha? Yung reference, 98%.
Yes, sir.
Okay. Because yung sa akin, at the moment, 90% lang sinasabi ko sa mga pasyente. More than 90% na. Okay. But if you say 98%, the all the more maganda. Na? Okay. So, then for the imaging, ultrasound imaging lang siya, di ba? So, it's not as good as the FMAB. Okay. Then the risk, you have to spell out the risk. No? Anong risk ng FMAB? Biopsy, the pain, di ba? May pain
Yes.
siya, may baka may bleeding kuminsan, no? Okay. And then for the ultrasound, meron, wala. May risk.
None, sir.
Theoretically, none. Ay, in reality, none. No? In practice, wala. Pero kuminsan, meron din. Depende dun sa gumagawa. No? High-dose ultrasound waves can cause some mga cystic degenerations. No? Pero usually, wala. No? Saka painless. No? Okay. And then, in terms of cost, saan mo nakuha yung mga data mo?
Sir, so ano po, FMAB po na rate ng UPCM po? Ay, ng PGH po.
Talaga? Okay. 800. Mura lang yan.
Ang 2014 po, sir.
Okay. Okay. Anyway, okay. The way to go about, okay lang yung basta matuto yung process. No? But you have to update yourself based on the recent. Parang ako, when I ask a patient to do something, now I usually ask, how much does it cost when you do it there? Then I remember all those information. Next time I know how to advise patients. Na? Okay. And then the last one is A, availability. Both are available. Okay. So between the two, you choose the FNAM. Diba? Okay. So which one will you, okay, the next question is, which one do you aspirate? The neck node or the thyroid? Diba?
The
That's an
node.
issue, diba? That's an issue, Patricia, diba?
Sir, can you do both po?
Of course, you can always do anything. Kaya medicine is problem-solving decision-making eh, di ba? Okay. Pag when you say you can do both, you're a maximalist physician. Okay, lahat gagawin, di ba? Minimalist, yung mga kailangan lang, na essentials lang, na? Okay. So ano, i-dissect mo nga pros and cons. If you do one,
Sir, if you do one, the yield might be less certain po.
less certain. Yeah.
Opo.
Will it matter kung ano? Tama. Theoretically, yes. Kasi dalawang positive, di ba? Lymph nodes saka ano, positive. No? Theoretically, tama ka, di ba? Okay. But is it needed? Di ba? So what are the chances that that lymph, kung positive yung thyroid mo, no? Yung thyroid aspirate mo, positive na rin yung neck node mo. Clinically kasi malaki, di ba? Malaki, di ba? Kung maliit siya, okay, baka magdududa ka. Is it really metastatic or not? No? Okay. But you have other options. Now, when you operate, you can take a look. Di ba? You can take a look. Is it metastatic or not? No? Okay. So when you do the operation, you can also have a diagnostic process there. No? Just by looking, aside from frozen section. Di ba? Okay. So, pwedeng isa lang. About, if you aspirate the lymph nodes positive, can you say that positive na yung ano, into thyroid? Pwede, di ba? Okay. Sabihin natin, gumawa ka ng dalawang, inaspirate mo yung dalawa, yung isa, hemorrhagic, yung sa thyroid. Pwede yan, di ba? Then, yung sa neck node, positive for papillary metastatic. Okay. So you can settle for the diagnosis already. Most likely from 90% magiging 99 na yun. No? Ganun. Okay? So it's a matter of how you interpret this, how you decide on things. No? Okay? Okay? So papillary CA, your pre-op diagnosis with neck node. Okay, you have the goal of treatment. Okay, so you have to explain to the patient now. So what are these various options based on the objective? Okay, so surgery, radiotherapy. You mentioned about radiotherapy and also your RAI. Okay, and then chemotherapy. Okay. So ang ililista lang ninyo doon, yung mga what you think are the those that you have heard commonly done. Okay? Yung mga irrelevant, wag mo isasama na sa table of options, na? Okay? Kasi and then if patients decide baka pwede itong herbal medicine, di ba? So isama mo, na? Okay? Put it on the table, na, of comparison. Then sasabihin mo sa herbal medicine, well, don't say 0%. Huh? In terms of effectivity, benefit, sabihin mo na 1% lang yan. Na? Okay? But in terms of the surgery, sabihin mo, 99%, wala rin 100%, 99%, tanggal lahat yan. Na? Okay? Chemotherapy, what's your experience with chemotherapy, the tyrosine 1? You can say that it's not indicated here, di ba? Okay. If you have a recurrent anaplastic or whatever, then you can use the tyrosine chemotherapy there, no? Okay. And then for the radiotherapy, how do you explain it? Hindi matatanggal lahat yan. Di ba? So probably if you have figures, probably 60% lang, then you still have to do the operation. No? And then for the RAI, ganun din. No? RAI therapy, you get some figures, no? To give to the patient. Sabi mo, baka 30% lang, no? Bago mawala, no? Okay. So then on the risk, of course, you explain the risk of the operation. You have scar if you want to do conventional. Okay. You have pain. You have hemorrhage. You have infection. You have anesthetic complications. No. Okay. Then radiotherapy. Don't just say acceptable. There is just say you have to spell it out. Okay. Radiotherapy, radiation. RAI, radiation. No. Ganon. Okay. Chemo, the side effects of the chemo. Then, of course, the cost, then availability. No? Okay. So once you have chosen, once you have presented all this data to your patient, this patient will say, okay, doc, sige, bahala ka na. Bahala na kayo. No? Okay. No, but sabi mo, hindi ako bahala, pero dapat malaman mo, no? Yung mga pros and cons, no? Ikaw mag-decide, no? Tinutulungan ko lang kita, no? Okay. So, ito yung patient-centered, na? Okay, don't just be paternalistic. Sabi mo, dapat ganon without explaining, na? Okay. So that in the end, kung kasi even with surgery, kahit na mataas ang success rate, 95%, 98%, there's small percentage of failure, na? Pag nag-fail siya, baka sisihin ka, na? Kasi hindi mo in-explain, na? The other options, na? Okay. So you have to explain the different options. No? So after that, the patient underwent the operation, okay, the pre-op preparations. No? Okay. Okay, so I won't go into the other details now. Okay, then you operate. Okay, what are the things that you watch out for? Ang pinaka-common problem dyan will be yung hypoparathyroidism. Na?
Signs of hypocalcemia po.
Okay. Why? Why? Compared to just total thyroidectomy. Mas mataas ang incidence ng hypocalcemia sa total versus subtotal lobectomy because hindi mo ginagalaw one side, di ba? Okay, kaya intact yung parathyroid, na? But with total thyroidectomy, meron ng high risk for hypocalcemia plus nag-neck node dissection ka pa. Yung blood supply, di ba? Yung blood supply is coming from somewhere along the big vessels of the neck, di ba? Okay. So, mas mataas ang incidence ng hypocalcemia. So, you have to tell the patients all of these things, na? Okay. Then, but tell them that we will try to avoid the complications as much as possible, but no guarantee, no promise, na? Okay. Then, post-op. Okay. Bakit? Shamil, ikaw ba nag-present ng post-op, no? You presented the post-op. So, as is ba yun? As is ba yung present mo? As is from the chart?
Yes po.
Bakit meron siyang levothyroxine right away?
Since nag-total thyroidectomy po.
Yeah, total thyroidectomy, tinanggal natin. Tama, no? Are you not, is there a plan, if there is a plan for further treatment like RAI, now usually we don't give the levothyroxine right away. Okay. So dapat may plano na yung surgeon ahead, na? Okay, if there's a plan for RAI, na, then you don't give the levothyroxine right away. Na? So papababa mo yung, papataas mo yung TSH, di ba? Bago mo ibigay yung RAI, na? How about the, ano pa yung isa, yung serum calcium? Nagbigay na kayo ng
ng serum calcium, ay ng calcium and vitamin D.
Right away, no? I suppose may baseline. Bago,
Ang nakita ko lang po yung 6 hours post-op.
oo nga. So yung problem with the hypocalcemia, no? Okay, so one, pwedeng you can just watch and wait, di ba? Observe. Kung meron, then that's the time you take the test. You have the serum calcium test done, then give yung calcium gluconate, na? Or you can, number two approach will be you have the baseline already, na? Sometimes yung mga endo will always dictate to the surgeon, get the baseline even before the operation, no? Okay. Then after the operation, take another one, no? But that will consume, it will consume a lot of resources, no? Okay. And then after that, kung normal yung right after the operation, you can observe, no? Kung mababa, then it's time you give, no? Pero yung sa inyo, yung sa nilagay mo, binigay na niyo kagad, di ba? Okay.
Yes.
Okay. That's another way. You give the parang malaking probability mag-hypocalcemia siya, ibigay mo na kagad. Na para hindi siya mag-develop ng symptoms, na? Okay. Now, the fourth approach will be wala nang serum calcium, just give the supplement. Okay? Tuloy-tuloy lang. Okay? So there are several approaches there, no? In treating, in preventing, in managing hypocalcemia. Na? Okay. Okay, any questions? Bakit hindi ginawa yung laryngoscopy? Is it needed?
Sir, it's as far as I'm aware po, it's more for being sure po that if ever there's post-operative parang problem with recurrent laryngeal nerve palsy po, we would have a baseline for the status of the patient's vocal cords. Parang yun po yung purpose niya according to our previous discussions po. However, I think for this patient, possibly it was deferred na po since there was no issue naman po. He did not complain po of hoarseness or any other symptoms aside from global sensation. So maybe that's why it was deferred po.
Okay. So yun ang sinasabi ko. Maraming information that you will be getting from the internet. Maraming different practices. No? Okay. Some would do an indirect laryngoscopy pre-op as a baseline. Okay. Some would not do. Okay. Some would even hindi lang baseline, just want to check. Baka sabihin nila kasi thyroid CA nila. To check the extent of the involvement, no? Baka may asymptomatic na palsy of the recurrent nerve, okay? And then, so some would just wait and see, no? Lalo na yung mga surgeon who are very confident na in doing their surgery. I-preserve ko yung para yung recurrent nerve niya. No? I don't need the laryngoscopy. No? Ganun, no? So problem solving, decision making by each surgeon, by each physician. Na? Okay. 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 Ano pa? Dami, no? Any questions? Okay, yung
Sir,
mail.
I have a question po regarding imaging, sir. If ever would there be a sign or symptom po of the patient that would make you consider that the vessels po are encased na po by the mass, which might parang prompt na magkaroon po siya ng CT scan or other imaging po pre-operatively.
Yeah, there's room for that. Yeah, sabi ko, indications. The word is indications, no? So, but this is dictated by your clinical findings. If your clinical finding shows that there's a huge mass na talagang hindi na gumagalaw, yung neck node, no? Hindi gumagalaw, no? At most likely, baka na-encase na yung big vessels, then you get the CT scan. No? Okay. So there's a room for that. Basta everything that you do, there must be an explanation why you are doing it. Na? Okay. Okay. Hindi de kahon lahat. Na? Okay. Any more? Bakit ultrasound guided pa biopsy? Laki-laki na. Okay, that's another issue, di ba? So in the Philippines nowadays, nagiging rampant na yung ultrasound guided. I'm so saddened by those practices. Ang laki-laki na, even sa breast mass, laki-laki na. Pwede namang gamitin yung kamay to ano, no? Kahit sa thyroid, you don't need the ultrasound, no? Pero de kahon na ngayon may ultrasound. So how much will it cost when you ultrasound guided? You have to pay for the ultrasound facilities, no? Then you have to pay for the pathologists, the pay the surgeons, no? Okay. So take note of that, no? So kung kapang-kapa na, just even in the office, just put in a needle, tusukin mo lang, tapos na, di ba? Okay. You can do ultrasound guided. If it's too small, mahirap kapain, no? Mahirap kapain. Then you do the needle ultrasound guided, no? Okay. So the other one, the last one probably, kasi it's almost 12:30. You mentioned about male and sex, male sex and then the age, no? Sama na ako yun? Who presented this?
Sorry. Sir, actually, yun po yung gusto ko sana itanong.
Okay.
May dun po
Bakit hindi mo
kasi sa
tinatanong ka
Harris.
muna? You have to wait for me to ask you.
Pero hindi ko sure kasi, sir, kung gaano ka non-relevant, pero how important it would be sa discussion. Pero dun po sa may mga articles po and sa Harrison's, yun po yung sabi na male sex and young age po yung mas pag male sex and young age, panakita ng thyroid nodule, dun po mas iisipin mo na malignancy po siya.
Okay, ganun yan. Ganun yan, ha? Okay. So of course, you have data showing prevalence of thyroid cancer in certain age group, no? Okay. But the first thing to do is to rely on your PE findings. No? PE findings, regardless of age, regardless of sex. No? Okay. So PE findings. Okay. Doesn't mean that may bukol dyan sa 20 years old, cancer na yan kagad. No? Okay. That's also the same goes for the family history. Huh? Okay. Dalasan kasi kayo, yung mga a lot of clinicians, pag may family history, CA na yan. No? Okay. So no, you have to examine the patient. No? Okay. Even though you have family history, let's say 25 years old, no? May thyroid nodule, may family history of thyroid cancer. It doesn't mean, pero cystic siya, it doesn't make it thyroid cancer, di ba? So PE muna, PE, no? Okay. So don't use the age and the sex, the age and the sex and also the family history as the basis for suspecting a particular diagnosis, no? Okay. Mahina yun, mahina, no? Okay. Kung wala ka na talagang makuwang basis from your signs and symptoms, okay, you're using prevalence, probably you can use it, no? Okay. But usually you have PE findings already, no? Okay. Is that clear? I hope you
Yes,
can.
sir.
I
Yes,
hope
sir.
you can stop other people from using that concept. Diba? Okay. Basta age and sex. Saka yung isa pa, yung 55 versus 45. Ang gulo, no? Francis, yung mo, 45 ginamit mo, yung sino ba? Shamil, you use 55. Diba?
Yes,
More than
based
55.
on the-
Which is which now? Which is which? Magulo, no? Okay. So even tingnan mo, even in the literature magulo, dati 40. Then may nagsabing 45. Ngayon may 55 na may cut off na 55 na. And then in the Philippines, there's a question nga But a lot of our Filipinos do not know their exact age, saka yung age na sa birth certificate, o kaya kung dinideclare nila, hindi rin tama. Di ba? Do you agree? Eh kung 45 siya, let's say 55 is the cutoff. Kung 54 lang siya, no? Does it make a difference? Eh, baka understated yung ano niya, age niya. Okay. So take note of that issue, no? Using the age. No? So make use of the clinical findings na lang, yung signs and symptoms, no? Okay. Okay. I think that's about it. It's already 12:30. Okay. So any more questions? Lana?
No more questions po, sir.
Lana? Okay. So before we leave, I put on the chat box yung link to that Olete. Okay. Nakita niyo lahat? Can you click on it? Ma-open ba
Yes
niyo?
po, sir.
You can open it?
Yes, sir.
Okay. So please take it now. Okay. Kung ayaw niyong kunin, okay lang sa akin. I won't force you. Okay? But if you take it, I'm not going to say I assure that you will learn more things. Okay. Okay. But I'll give you bonus points. Okay. If you get a perfect score. Okay. You can do it 2 tries, 3 tries until you get a perfect score. The bottom line there is parang common yan ipa-practice mo. No? Okay. If you disagree with my answers, okay, don't make it an issue. Just tanggapin mo lang muna. Okay? Okay? Kasi yung mga test ko minsan mahirap gawin, tapos kung minsan may questions sa answer, di ba? Okay. Okay. So all of you got it na?
Yes, sir.
Okay.
Sir, would there be a deadline po for this? Because we're assigned po to operating room assist po today. So some of us will have to go back na po after the SGD.
Pwede. Pwedeng bukas. Last day na ni bukas, di ba?
Yes po, sir.
Sige, hanggang bukas pwede, no?
Thank you po, sir.
So, okay, so I'm going to give the grades only tomorrow after I receive all, no? Okay?
Okay po.
Okay po,
May
sir.
bonus yan eh. Okay, let's now have a group picture taking.
Yay.
Yes, sir. Wait.
Okay.
1, 2, 3.
1, 2, 3. Okay.
Okay.
Sige. Lagay na lang niyo sa yung feedback niyo sa evaluation form. Okay, any feedback, 1 sentence, 1 statement lang, sige. Marami kayo natuto, bago?
Yes, sir.
Naguguluhan
Yes
kayo.
po, sir.
Yes, sir.
No, sir. Very high yield po.
Ayaw.
Okay. Sige.
Matuto kami, sir, magtipid ng diagnostics.
So that's going to happen in the real world after you get out of PGH. No? And I'm so realistic also, sabi ko sa'yo, you're still students, wala akong magagawa. You just follow muna. Kasi you have to pass the test. Tama? Okay. Okay. So let's call it a day. So nice meeting you. Okay. So if you have any questions, feel free to contact me anytime. No? Okay. Bye-bye.
Thank you, sir.
Thank you po, sir.
Thank you po, sir.